is to identify the probable cause of shock. In trauma patients, this process is related to the mechanism of injury. Also consider all types of shock. Although most injured patients in shock have hypovolemia, they may suffer from cardiogenic, obstructive, neurogenic, and/or septic shock. Patient management responsibilities begin with the recognizing of the presence of shock. The patient's response to initial treatment, coupled with the findings of the primary and secondary surveys, usually provides enough information to determine the cause of shock. Remember, hemorrhage is the most common cause of shock in trauma patients. The shock state depends upon an understanding of basic cardiac physiology and blood loss pathophysiology. Cardiac output is defined as the volume of blood pumped by the heart each minute. This value is determined by multiplying the heart rate by the stroke volume, or the amount of blood that leaves the heart with each cardiac contraction. Stroke volume is classically determined by preload, myocardial contractility, and afterload. Preload is the volume of venous blood returned to the heart, which is determined by venous capacitance, volume status, and a pressure differential that determines venous flow. Hemorrhage reduces preload. The volume of venous blood returned to the heart determines myocardial muscle fiber length after ventricular filling at the end of diastole. According to Starling's law, muscle fiber length is related to the contractile properties of myocardial muscle. Myocardial contractility is the pump that drives the system. Simply stated, afterload is resistance to the forward flow of blood. Early physiologic responses to blood loss are compensatory, and these mechanisms are limited. If shock is prolonged, end organ damage and multiple organ dysfunction can result. Tachycardia may be the only early sign of this physiologic derangement. Shock is optimally recognized during the initial patient assessment. After ensuring a patent airway and adequate ventilation, carefully evaluate the patient's circulatory status for early manifestations of shock, such as tachycardia. Do not rely solely on systolic blood pressure as an indicator of shock. Compensatory mechanisms can prevent a measurable fall in systolic pressure until up to 30% of the patient's blood volume is lost. Massive blood loss may produce only a slight decrease in initial hematocrit or hemoglobin concentration. Thus, a very low hematocrit value obtained shortly after injury suggests either massive blood loss or pre-existing anemia, and a normal hematocrit does not exclude significant blood loss. Base deficit and/or lactate levels can be useful in determining the presence and severity of shock. Serial measurements to monitor a patient's response to therapy are useful. Remember, in trauma patients, determining the cause of shock involves considering the mechanism of injury. Most injured patients in shock have hypovolemia, but they may suffer from cardiogenic, obstructive, neurogenic, and/or septic shock. To recognize and manage all forms of shock, maintain a high level of suspicion, and carefully observe the patient's response to initial treatment. Initial determination of the cause of shock requires an appropriate patient history and expeditious careful physical examination. Selected additional tests, such as chest and pelvic X-rays and FAST exams, can confirm the cause of shock but should not delay resuscitation. Hemorrhage is the most common cause of shock after injury, and virtually all patients with multiple injuries have some degree of hypovolemia. The focus of treating hemorrhagic shock is to promptly identify and stop hemorrhage. Sources of potential blood loss, such as the chest, abdomen, pelvis, retroperitoneum, extremities, and external bleeding, must be quickly assessed. Chest X-ray, pelvic X-ray, FAST, diagnostic peritoneal lavage, and bladder catheterization are methods of locating bleeding. The most effective method of restoring adequate cardiac output, end organ perfusion, and
There are 4 standard views in the FAST exam: the pericardial view, the right upper quadrant view, including the interfaces of the diaphragm and the liver and the right kidney in Morison's pouch, the left upper quadrant view, including the diaphragm-spleen interface and the spleen-kidney interface, and the suprapubic view. Start by viewing the heart using the subxiphoid or the parasternal view. Fluid within the heart should appear black. The presence of fluid outside the heart within the pericardial sac is abnormal and is consistent with pericardial tamponade. The right upper quadrant view is a sagittal view in the mid-axillary line at approximately the 10th or 11th rib space. Visualize the diaphragm, liver, and kidney, as well as the entire hepatorenal fossa or Morison's pouch, looking for fluid. In a traumatically injured patient, the presence of fluid between the diaphragm and liver, or liver and kidney, is blood until proven otherwise. The left upper quadrant view is a sagittal view in the mid-axillary line at approximately the 8th or 9th rib space. The diaphragm, spleen, and kidney interfaces are visualized, and as in the upper right quadrant, any fluid visualized is blood until proven otherwise. The suprapubic view is a transverse view that is best to obtain prior to placement of a Foley catheter. In this view, the area behind the bladder is examined for the presence of fluid, which, if present, is abnormal and consistent with hemorrhage in the trauma patient.
Method of restoring adequate cardiac output, end organ perfusion, and tissue oxygenation is to restore venous return to normal by locating and stopping the source of bleeding and restoring adequate circulating volume. Most injured patients who are in hemorrhagic shock require early surgical intervention or angioembolization to reverse the shock state. Therefore, the presence of shock in a trauma patient warrants the tamponade, tension pneumothorax, neurogenic shock, and septic shock. Even without blood loss, most non-hemorrhagic shock states transiently improve with volume resuscitation. Defined as an acute loss of circulating blood volume. Although it can vary considerably, normal adult blood volume is approximately 7% of body weight. The blood volume of obese adults is estimated based on their ideal body weight, because calculation based on actual weight can result in significant overestimation. The blood volume for a child is calculated as 8 to 9% of body weight, or 80 to 90 milliliters per kilogram. The physiologic effects of hemorrhage are divided into 4 classes, based on clinical signs, which are useful for estimating the percentage of acute blood loss. The clinical signs represent a continuum of ongoing hemorrhage and serve to guide initial therapy. Subsequent volume replacement is determined by the patient's response to therapy. Review the 4 classes of hemorrhage. The clinical symptoms of volume loss with Class 1 hemorrhage are minimal. In uncomplicated situations, minimal tachycardia occurs, with no measurable changes occurring in blood pressure, pulse pressure, or respiratory rate. The clinical manifestations of Class 2 hemorrhage can be exaggerated by other fluid losses. Some patients in this category may eventually require blood transfusion, but most are stabilized initially with crystalloid solutions. The priority of initial management is to stop the hemorrhage by emergency operation or embolization if necessary. Most patients in Class 3 hemorrhage require packed red blood cells and blood products. The degree of blood loss with Class 4 hemorrhage is immediately life-threatening. These patients frequently require rapid transfusion and immediate surgical intervention.